Hello, everyone. Good evening. Can you hear me? All right.
Yeah, definitely.
Okay, good. All right. Okay, thank you very much for this kind invitation. Firstly, I just want to acknowledge the chairman, Dr. Debashe, the moderators, Professor Rajesh, as well as Professor Sharma. Thank you so much for putting all this together. Indeed, after listening to the first few lectures and talk, I'm really humbled when among the midst of this of your distinguished panel that I've heard, and of course here. I also want to acknowledge Nikon and Optos for the invitation, and of course this you're all India Ophthalmology Society for putting all this together, and congratulations on organizing this successful talk in that sense. My talk this evening will be on the clinical experience of Optos. Definition of wide field, the earlier speaker has mentioned, of course, by default, fundus camera provides a 30 to 50 degrees field of view, and to really enlarge this, we really have to change the traditional camera angle. And image angles larger than 50 degrees would be more or less be labeled as wide field. Definition of ultra-wide field, earlier speaker has mentioned, it's not really been accurately defined. Some have defined it as more than 100, but some has defined it, gaining popularity, defined it more than 150 degrees of view. This is a picture from the ETDRS study where we can see the 7 circles indicating the 7 subfield, as well as the early Optos 100 with a square with limitations of the retinal field, but now with the Optos 200 degrees, we can have a wider field. And here, the imaging capabilities of the Optus would be that of the 200, as the early speaker has mentioned, as well as incorporated in it will be the fluorescein, autofluorescence, as well as the ICG in the California system. We have also seen this familiar picture. We know and understand that there are many signs of retinal pathology which lurks in the periphery. These signs may go undetected, as we have heard from earlier speakers, using traditional examination techniques. And again, long before the patient presents with any symptoms. With the ultra-wide field, this allows for the guided treatment and provide additional diagnostic information to properly administer treatment. And again, earlier discussion, we have mentioned it can also be imaged through an undilated 2.2 millimeter pupil. Actually, I want to retitle my talk rather than on just clinical experience, but rather seeing more than just ultra-wide field. Again, we have heard from the experience from earlier speakers, the excellent presentation, that you can see so much from ultra-wide field. What can we actually see more than ultra-wide field? We are all familiar with the normal fundus photograph with the disc as well as the fovea macula, but essentially this is a normal fundus photograph in the presence of a ultra-wide field. Studies have also shown even with the 7 subfield ETDRS with a ultra-wide field, it can give up to 3 times more than that of a 7 times ETDRS subfield. How so? In other words, a normal fundus photograph compared to ultra-wide field, ultra-wide field may be able to give up to 20 times more than that of a normal fundus photograph. Typically, this is a patient you can see represented with floaters. Again, a lot of surgical pathology can be imaged with a ultra-wide field. In the superior nasal quadrant, you can see a retinal tear. And again, here highlighted within the red circles, the retinal tear. Patient did not want to get a laser that day. 1 week later, patient was more symptomatic with a bit of shadow. And you can see here that patient developed a little bit of limited retinal detachment as well as subretinal fluid. He underwent a laser retinopexy, I can see by the laser scar, but however, a week later, he presented with more symptoms of a retinal detachment that needs retinal detachment surgery. So this, in that case, would be both instructive as well as in this day and age of medical legal prevalence, we need to document that we have actually counseled the patients with photograph, but however, patients would like to delay treatment and subsequently develop complications. It's also important to document with the opposite eye some lattice degeneration which predispose the patient to retinal detachment, as the earlier speaker has also mentioned. Here you can see the lattice degeneration. Here again, documentation of the retinal tear, again with 360 degrees burn around the tear to secure that the tear has been nicely secured with laser. Again, on the opposite eye to document the white without pressure that this patient has. It's not easy to document a peripheral retinal tear with just normal fundus photograph. Here you can see a very peripheral retinal tear which may not be easily picked up, but easily picked up on the Optos Ultra-Widefield. Here highlighted within the red circle. And again, over here on a magnified view within the red circle would be very peripheral retinal tear. Later on, earlier speakers have also mentioned, and later on I'll emphasize also some uses of the red and green laser or red and green channels. But here we can use the green channels to highlight the retinal pathology with the green laser. So what else can we see beyond that of ultra-wide field? Yes, we do see forest through the trees, but sometimes you want to go back to a bit of details and not look at so much ultra-wide field. What do I mean by that? This patient, we can see that it has 4 quadrants of dot blot hemorrhages. You can see as well as some very peripheral ones, even in the temporal periphery, as well as some cotton wool spots on this ultra-wide field 2 years ago. Patient, you can see when I focus on down onto the photograph, you can see that we don't lose much of the detail. So the resolution on a camera must not be just on a big picture, but also we must be able to capture a close-in, close-up photograph with the details. When patient came back again, of course, defaulted after 2 years, came back again, it seems that the retinopathy seemed to have resolved, but however, the sugar level did not tell the same story. In fact, the sugar level has gone up. So how does the sugar level go up and the retinopathy seems to have resolved? Patient actually came back because she presented with a floater in the opposite eye. And here you can see that patient has some evidence of vitreous hemorrhage. When we look back at the photograph 2 years ago, again, patient has more florid retinopathy signs. You can see of the dot blot hemorrhages in the 4 quadrants as well as the cotton wool spots. So does it mean that the patient actually has better resolution of retinopathy despite sugar level being elevated? And patient came back because of cinematic vitreous detachment. Again, this is what she presented with. But we go back to the photograph done this time round, we can actually do miss on the nasal aspect, a front of new vessel, despite the almost resolution of the peripheral retinopathy lesion. Zooming in on the details of the posterior pole, we can actually see highlighted within the red arrows the details of the front of new vessel. Here, even with the magnified same view on the Optos, which I did not do any calibration to, you can see that the new vascularization, the new vascular front can be distinctly seen. And we go back to the photograph again, 2 years magnified view, you can see again the florid dot blot retinopathy signs, microaneurysm, and cotton wool spot. But however, the new vessels was actually absent. So it's important not just to have a big picture, but also do not lose the details. How about seeing beyond colors that the Optos gives? Again, earlier speaker has alluded to the color image with the red-green separation. This is, again, you can see the picture on the left-hand side of the choroidal nevus, the green channels, which actually highlight the sensory retina to RPE, and the red channels or the red laser for the RP or the deeper choroidal picture. So you can see that this choroidal nevus does not appear on the green channels, but on the red channel, which highlight the choroidal pathology. Ultra-wide field colors, again, putting in the ultra-wide field red laser where we accentuate the choroidal blood vessels, but the green laser will highlight and emphasize the retinal and pre-retinal pathology better. Again, this is a patient you can see with pan-retinal photocoagulation. Applying the green laser, we can see where the lasers are or areas of insufficient laser, for example, in the temporal quadrant. This patient also had laser done, but probably had some proliferative changes evidenced by the remnant of the vitreous hemorrhage. Here you can see application of the red laser will highlight the retinal vessels as well as the hemorrhage better. But again, without losing details, zooming in on the same picture, color fundus photograph, applying the green channels of green laser, we want to highlight the areas of new vessels that may be missed using the color fundus photograph. Again, this patient, diabetic retinopathy, multiple lots of pan-retinal laser have been done. Again, we want to apply the green laser or the green channel to highlight the retinal sclerosed vessels as well as the pre-retinal fibrotic membranes that in this patient. So again, on the opposite eye, the pre-retinal membranes have been highlighted on the green channels or the green laser, but also in an institution where we also want to show the residents the areas of insufficient or deficient laser that can be applied or topped up with this patient using the green channels. Again, post top-up laser, you can again apply the green channels or green laser to show them that again, it has been nicely topped up. How about seeing beyond the still photograph? What is seeing beyond the still? This is another patient, again, with pan-retinal photocoagulation done, again, probably proliferative in nature, evidenced by the pre-retinal and vitreous remnant hemorrhage. The green channels, green laser will highlight the retinal pathology well, but sometimes applying the 3D function on this, on my California, you can actually see the areas that is deficient or has been adequately or inadequately lasered, in a sense, with a 3-dimension picture. How about seeing beyond the patient's request or the complaint? And what does it mean? These patients came in requesting for LASIK, refractive surgery. What do we see in the periphery? Not much pathology. But again, without losing details, we go zoom in on the center of focus around the disc. We can actually see areas of cotton wool spots in this young lady who requests for refractive surgery. In the presence of flame hemorrhages, multiple cotton wool spots, not forgetting blood disc margin and disc swelling as well as sclerosed vessel, this patient has a hypertensive retinopathy, which can be diagnosed even on the wide field without losing the details. And of course, on the opposite eye, again, we do see the cotton wool spots as well as some sclerosed vessels. This diagnosis is obvious. Patient presented symptomatically with blurring of vision, found to have branch retinal vein occlusion on the superior temporal aspect of the left eye, successfully lasered, as you can see here. So this is a close-up view of the successful laser on the sectoral laser for this branch retinal vein occlusion, green channels showing the sclerosed vessels as well as the extent of the laser, both surrounding the sclerosed vessels as well as to the far periphery. But looking beyond the patient complaint of the left eye, we image the right side as well routinely. Here, what do we see? Almost looking normal, almost normal looking retina, but you might just spot a sclerosed vessels inferiorly. So zooming in, you can see there's a sclerosed vessels inferior to this. In this asymmetric right eye, you can also be able to see the darkening supplied by this retinal vessel. This wedge-shaped distribution, again, will be manifested, enhanced, and highlighted on the green channels, as you can see here, where it highlights the retinal pathology better. Again, another patient with untreated branch retinal vein occlusion with the green laser follow-up. Again, we can see the resolution of the hemorrhages as well as the extent of the laser, and again, enhanced, accentuated with the green laser. How about seeing beyond the obvious? How can ultra-wide field help us see beyond the obvious? Here we can see patients with lots of vitreal opacity. This reflective crystals rather looks like synchysis scintillans to me. And again, do we miss anything in the posterior pole? Just like this synchysis scintillans, a degenerative condition of the vitreous, here we also can have a degenerative condition on the retina or over the macula. It looks also refractive in nature. Again, you can see at the red arrows, these are actually reflective drusen. Here on the close-up view, without losing details, you can see the also, you can see that also green, yellowish reflective in nature, like the synchysis scintillans of cholesterol crystals. It may looks like on a white field, just like those crystals, but it's actually on the macula. Again, this will be confirmed on the autofluorescence looking at the red arrows. So this brings me to the next point of seeing black and white. This is a patient, again, where it looks like what looks like Salisbury-like, pseudo-inflammatory kind of macular dystrophy, where we do see all these white and yellow deposits or spots on the retina, which are obviously not drusen. There's also associated with this form an atrophic kind of a macular degeneration. Again, we do know in Salisbury, there's atrophy of the retina, RPE, retinal pigment, as well as the choroid slowly progressing towards the periphery. Here, enhanced with the red channels or red laser, we are able to see the retinal atrophy and green channel, with the enhanced the retinal pathology, but with the red channel, we enhance the choroidal pathology here, showing the choroidal atrophy. And what is instructive and here would be that application of the autofluorescence, where we show the atrophy of the retinal pigment epithelium, which is not actually seen on just on the color fundus photograph. And of course, on the patient's opposite eye, which also has the white and yellow spots, the disciform atrophy over the posterior pole. Here we do see some hemorrhages, retinal hemorrhages, which is also typical in SORS-B pseudoinflammatory macular degeneration. However, enhanced with the green channels, the hemorrhages, retinal hemorrhages is more obvious and highlighted, which we do not see again on the color fundus photograph. Here is a follow-up after patients has the retinal hemorrhages resolved. You can see a nice broad ultra wide field picture of the patient posterior pole with resolution of the retinal hemorrhages. Again, what is really useful here with the application of a autofluorescence to show that the posterior pole has undergone atrophy of the RP or retinal pigment epithelium, combined with the atrophy of the retina and choroid. Patient presented with poor vision in both eyes. And here is a close-up view of the patient pathology. And this is a patient's which you can't see on the fundus photograph. How about in retinal dystrophy? You can see there's quite a lot of peripheral chororetinal atrophy. Here, using the green channels, again, the retinal pathology is highlighted. And you can see over here that if despite the large areas of chororetinal atrophy on this red channel, you can also see the choroidal vessels being thinned out and being atrophic in this patient's right eye. This patient, similarly on the opposite eye, on the left eye, very stormy, very ugly looking kind of retina because there's lots of pathology in the periphery. But you can see that the chororetinal atrophy is mainly limited to the nasal superior and inferior to this, sparing the posterior pole, as compared to this next patient. Next patient, also retinal dystrophy, looks like retinitis pigmentosa with bony spicules pigmentation in the mid-periphery, but not as much as the earlier patient. By using the green channels, you can see the retinal atrophy, but on the red channels, you can see that the choroidal atrophy actually involves the posterior pole, even though the color and the retina did not show up very well. And again, on the opposite eye, not as much chororetinal atrophy, not as much bony spicule pigmentation as the earlier patient, but because of the choroidal pathology and atrophy, this patient actually presents with worse vision compared to the earlier patient. So here, a close-up view with the color fundus photograph, as well as the green channels and the red channels, looking at the attenuation and thinning of the choroidal vessels. How about looking at some routine cases? Here, one of the critics and skeptics about optics, I would say, is not so much, if you have heard, it's not so much the ultra-wide field capabilities, but really looking at medical pathology. Again, I've tried to move away from my earlier surgical pathology, but to showcase more medical retinal pathology, which is actually my interest. In this patient, you can see a bit of opacification or graying of the posterior pole with a powerful gray sheen in combination with the RP pigmentation and crystalline deposit. This will go for a diagnosis of PFT. Again, it may not show very well on this channel, but with the green channel, we know that this is a retinal pathology and the crystals usually be highlighted here in a PFT. This patient, this young girl, presented with photopsia and blurring of vision. You can see all these dots, whitish, yellowish dots in the posterior pole, as well as a periphery. Patient probably has Mutes or multiple white dots syndrome. And we know that this is not a choroidal pathology. Using the red channel will not be able to show any pathology, but with the green channels highlighting the retinal pathology or highlight the retinal location, you can see the white dots are actually accentuated. Follow-up color fundus photograph shows disappearing and resolution of the white dot. Choroidal red channels is normal, and again with the green channels, so resolution of those white dots. Again, another routine case would be that of pathological myopia. We see a lot in Singapore. Tessellated fundus appearance, RP atrophy, peripapillary atrophy, as well as tilted disc. Paving stone degeneration in the peripheral documented on one ultra-wide field, and as well as vascular straightening. choroidal thinning on the red channels, as well as the bearing of the sclera on the, as well as the thin vessels and retinal atrophy on the green channels. Again, on the opposite eye, typical pathological myopic fundus of peripheral changes and macular changes, as well as disc changes, choroidal atrophy and retinal atrophy. How about CSR? CSR, we do see quite a number, nothing much in the periphery, but again, on the green channels, we do not see retinal pathology. But again, just on the red channels where I highlight the choroidal, we can see there's probably a bit of hypervascularity of the choroidal blood vessels. But however, instructive and would be that of an autofluorescence where you can see the hyperfluorescence on the AF. This can be confirmed on a wide field fluorescein angiogram, which I'll talk about after this. You can see the ink blots kind of leakage on the right eye. And again, routinely would be that of screening the left eye where this patient has a double pathology. So these are some of the routine cases. How about seeing beyond the routine? Again, earlier speaker has also mentioned in a patient with RP or retinitis pigmentosa probably has weak zonules. And here we can see image the periphery of a dislocated lens here, again with a picture of the RP picture and a dislocated lens in one picture. How about seeing the flow finally? We do know that it's tedious and it's laborious for the technician to really image the peripheral capillary retina, especially in retinal vein occlusion, to really capture not just the central macular edema or ischemia, but also the peripheral fallout and peripheral ischemia. Here, okay, symptomatic left eye of this patient, but on the right eye, you can see it's normal, again, with the branch retinal vein occlusion, a magnified view of the branch retinal vein occlusion. Here on the fluorescein angiogram in the early frames, you can see the delayed venous return, as well as ischemia, as well as the capillary drops out in the later frames, capillary insufficient in the late frames. Here, zooming in of the macula, we can see the macular ischemia of this patient presented with poor vision. Good ultra-wide field photograph to document the slow resolution of the hemorrhages with the application of the sectorial laser, and again helped by the green laser. Interestingly, this patient opposite eye routinely with the help of ultra-wide field, looking like a normal fluorescein angiogram on the opposite eye, but you see these light bulbs on the superior part, which you probably miss. I missed them just clinical examination, and this swings the diagnosis, needing further investigation of this patient's right eye. How about in arterial occlusion? Here, a normal fundus photograph, you can see whitening, swelling, edema of the superior retina. Again, with the ultra-wide field, you can see the superior, almost hemifield of the left eye is actually involved. Again, this is a fluorescein angiogram, starting with the first picture on your top right, superior hemifield delayed retina, arm retinal time. Magnified view of this, you can see the delay, but you can see also that the macula of fovea is not really involved, fairly well perfumed. Patient actually has pretty good vision, except for a bit of patchy inferior field defect. Again, with the ultra-wide field, you can see the pale edema swelling retina on this color fundus photograph. Another routine or beyond routine cases, this will be a CSR evidenced by the pigmented tracks on temporal to the fovea. Not much on the green field, but here on the choroidal or the red channel, you can see the dilated vessels. And again, very important will be the autofluorescence applied here. Again, confirm on the fluorescein, the staining of the tract and the ink blots and the dilated choroidal vessels on the ICG. Again, patient has a double pathology, nicely documented on the ultra-wide field, dilated ICG choroidal vessels you can see here. Last but not least, I just want to have some examples of vitreous hemorrhage. Typical example of patient with dense vitreous hemorrhage, surgery to evacuate the vitreous hemorrhage. This patient has PCV, very common over this part of the world, polypoidal vasculopathy, evidenced by the huge peripheral subretinal as well as retinal hemorrhage in the periphery. So here we can document the slow resolution of the hemorrhages, and we can more or less confirm in the fluorescein angiogram part. However, we do know that PCV is an ICG diagnosis. However, this patient was allergic to ICG. I could only document some leakages in the periphery with the fluorescein angiogram. This last patient is probably more typical in your part of the world. Patient presented with vitreous hemorrhage. You can see some lasers applied to periphery and some remnant vitreous hemorrhage. Here, with extensive vascular involvement, peripheral ischemia, new vessels, this will go for diagnosis of Ewe's disease confirmed on the fluorescein angiogram. And just to document with the ultra-wide field, document the pre-retinal hemorrhage or from the new vessels at the superior nasal areas, as well as extensive nasal laser that has been applied. So seeing more than ultra-wide field, we do want to go back to the details. We look beyond the still and photos. We want to look beyond the obvious, beyond the routine, as well as we do have black and white with the red-green channels, as well as autofluorescent, as well as a fluorescein angiogram and ICG to make it a compact kind of multimodal imaging on the Optos Widefield system. On behalf of my team, I just want to thank you very much for your attention and a kind invitation. Thank you very much.